been on some sessions, but there are just some sort of housekeeping issues that we just want to touch on. So just in terms of background noise, I sometimes equate our systems to a little mouse running around in a wheel, and it's tightening an elastic band, and if that elastic band gets too loose, then it all falls apart. So please keep your microphones off if you can, just to mute the sound and make sure we can hear properly. You can have your camera on or off, whichever you feel most comfortable with. I have to say, though, if you're in the trust, sometimes turning your camera off helps improve that connection stability. But again, that's up to you. I will keep mine on so people can see me. In terms of meeting etiquette, if people could just use the hands up function when they're wanting to speak, that'd help us. There's also the chat function, and we're hoping that people will use the chat function as we go along. We will be saving anything anyone puts in chat to share with other people as well, so please feel free to do that. In terms of SHSC staff, and don't ask me how to do this, but you might want to turn off your VPN connection, because that also helps with the stability of the connection. We are recording this session. It's a live session. By attending, you've kind of given us tacit permission for us to record you, and that's because we want to be able to share this a little bit more widely with other people. Just on that note, the person in the background doing all the technical stuff for me is Gurkha. I'll let you introduce yourself, Gurkha. Your sound's off, Gurkha, sorry.
Yes, hello. So my name is Gurkha Lange, and I work with the quality improvement team. And yes, I'm in the background doing all the tech and hoping to do a good job with it.
Thanks, Gurkha. Gurkha will keep an eye on the chat, and she'll bring in any kind of pertinent issues at the right time. But she'll also, more importantly, keep us to time and move us on. We have got quite a lot of questions in terms of the workshop that we're going to want to answer. So Gurkha will just keep us to time and move us along. Okay, next slide, Gurkha. So today in this workshop, we're focusing on sexuality and sexual safety in mental health services. I think it's really important in terms of setting the scene, just to say that the Trust is involved in a lot of work at the moment around sexual safety and focusing on sexual safety. And indeed, we have signed up to the National Sexual Safety Collaborative, and there is a Back to Good work stream focused on sexual safety within our Trust. Also, on a weekly basis, my team release a lessons learned from serious incidents into the weekly communication digest, and that this week will be focused on sexual safety, so people will be able to see that, and we will be sharing this session more widely. Okay, Gurkha. So in terms of setting the scene, in 2018, the CQC facilitated an event which was a national event to with stakeholders explore some of the current issues regarding sexual safety and mental health inpatient services. And from that, there was this agreement that from all stakeholders that sexual safety of service users, and I might add their staff, should be a priority for all mental health services. Okay, Gurkha. So I think we know that a lot of patients accessing our services have experienced significant trauma and or lack capacity in areas regarding sexual consent. And I think we all know that care needs to be taken in regarding the impact and possible re-traumatization of people who have been supported by our mental health services. And there is a robust co-produced evidence-based training package that needs to be thought about and put together in terms of helping our staff and patients in terms of maintaining their safety and well-being going forward. Thanks, Gurkha. So from one of the key things that I think is important for us to think about is that from the CQC analysis, they looked at 60,000 reports, and from that they found around 1,120 sexual incidents involving patients, staff, visitors and others. and they were described in these 919 reports, and some of them included multiple incidents, and more than a third, so 457 of those, were categorised as a sexual assault or sexual harassment of patients and staff. And I think that is probably just scratching the surface of what might be going on, and I think there's more to understand around that. And again, just as an addition to that, there is a lot of work going on in the Trust to look at our data and to start understanding our incidents when they're reported. Thanks, Gurka. So what we know, what the providers and people who use services told the CQC was that people who use mental health inpatient services don't always feel staff keep them safe from unwanted sexual behaviour, that clinical leaders of mental health services don't always know what good practice is in promoting the sexual safety of people using our services and of the staff, that many staff don't have the skills to promote sexual safety or to respond appropriately to incidents. Ward environments, and I think this is something we well understand, and again there's work underway to try and improve this, but ward environments don't always promote the sexual safety of people using services, and that staff may underreport incidents, and that reports may not always reflect the true impact of the person who is affected, and that joint working with other agencies such as the police doesn't always work well in practice. Okay, thanks, Gurka. So in terms of the scene setting, some of the key messages were that people who are admitted to mental health inpatient units do have a right to feel safe and be sexually safe. Administrators and managers and clinical leaders of inpatient units have got a responsibility to ensure sexual safety through preventative measures and by giving prompt responses to sexual safety incidents, and that can include policy, workforce development and these environmental factors. Sexual safety includes being free from sexual assault, sexual harassment and sexual activity. And one thing that in particular in the training sessions that I do, risk updates that I try and make clear to people, is that sexual activity is inappropriate in inpatient settings, and staff are responsible for making sure that patients are aware of this. Okay, thanks, Gurka. So again, with some of the key messages, sexual assault, abuse and harassment are potential crimes and are always unacceptable. Responses to sexual safety incidents should be trauma informed, and again that might be something we can touch on in our workshop session. They shouldn't be judgmental or punitive. Services should consider patients' human rights and other rights protected by legislation in all our decision making. Patient consent and their preferences and involvement in decision making are paramount, really important in considering how we respond to sexual safety incidents. Patients and other consumers and carers and families should be involved in the development of our policies and procedures, and that across all the ranges of mental health services we should be developing local policies and procedures consistent with the guidelines. Thanks, Gurka. So I just wanted to mention trauma-informed assessment before we move on, because I think this is something as we've gone along, we've become to understand more about how early trauma or trauma can affect an individual, and in additionally assessing someone's sexual vulnerability, we need to be trauma informed, and risk assessments should include some mandatory questions that are focused on past trauma, and that can include childhood physical, emotional and sexual abuse, experiences of family violence, including intimate partner and elder abuse, adolescents who use violence, etc., and experiences of violence in the wider community, including physical or sexual assault and harassment, and experiences of witnessing violent events. Thanks, Gurka. So what I want to do now is start us talking, really, and that can include the chat, and it can include people having their say on the questions that I'm going to ask. let's think about the questions carefully. This is a safe space. I want people to be able to speak in the best way that they can. I've lost the presentation, Kirk. I don't know about other people. Okay, great. So first things I want us to think about in terms of questions. Next slide, please, Gurkha. So I wanted us to just talk about and think about assessing the vulnerabilities and risks. So hopefully people have got things to say about each of these, but for this first part, I wanted us to think about the assessment part of the process. So what do people think about how do you assess the risk of sexual vulnerability? Yeah, does anyone want to sort of jump in? Okay, I'm not seeing. Okay.
Hello.
Hi.
So yeah, that's really good overview to kind of get us started. Thank you for that, Vin. And I particularly like the trauma-informed assessment bit as well, which I think would be great in our trust and very much needed and will really improve service user and staff understanding really of what people's needs are. So in terms of how can we, what was the question? Because I did have an answer. Oh yeah, how do you assess the risk of sexual vulnerability? I think it's a bit like, I think it's a process rather than a question. So I think as part of assessing the risk, it's part of the initial formulation meeting on the ward, where a care coordinator or somebody who knows the person well, whether it's care coordinator from where the person's been referred from, or whether it's family, the person themselves having an input, but it's about getting people in a room and asking questions. What do we already know? We may be able to ask the person themselves about what might be difficult for them, or it might be something that people have already done when they are in the community and that's a piece of work that can be done. But just thinking about how do you assess, I think it starts from getting a holistic group of professionals to integrate their approaches and to ask together what would be the signs, what's happened before, what would be the signs, what do we know about this person. I've gone on.
Oh, that's great, thanks, Kate.
Thank you.
I think we've got another hand. Just trying to see who it is. Sorry, I've lost my screen. James?
Can I just say, I've been on the wards. I'm a service user. So I've been on the wards multiple times. And in my understanding, the wards are quite a sexualized environment, and quite a lot of people there suffer from sexual disinhibition. You know, I honestly think the best way to protect people is to have separate wards for men and women. That to me seems the most simple and basic way you could start to improve things in this area.
Thank you, James. I think that is an area where the trust are focused on at the moment in looking at single-sex wards. But that is a really important point. Thank you, James. So in terms of responding to people's needs who identify as lesbian, gay, bisexual, or non-binary or transgender, do people think that we do enough around that in terms of assessment? Rodri?
Sorry, I was just thinking about the previous question.
No, that's okay, Rodri.
No, just in terms of thinking about, it's not how we go about assessing the risk of sexual vulnerability. It's also in part, do people feel they have the skills and the, so it's that sort of, do we as a trust develop and offer people a sort of training that allows them to start to think about these things and to ask questions with confidence. Because because I mean, as with, something like death or kind of, illness and all sorts of things, they're sensitive areas. And so, so obviously we think about formulations and about people's experiences, but when we come to directly speaking to people, we need to ask ourselves, I think, do we have the kind of skills and the skill sets, and do we train people to be able to ask in a kind of sensitive and helpful way? And that probably applies to the second one as well.
Yeah, and I think training is really important, and I think it is going to be vital going forward. And I was saying to Gurka when we were setting up this session just prior to this, it's amazing, isn't it, that when I did my training, I won't tell you how many years ago, but as a trainee nurse, we did activities of daily living, and that was one of the focuses that we had in our training. And as part of that, sexuality was one of the questions that you would ask about. And people in that over 20 years ago were saying, well, what do we ask about sexuality? And it's almost like a taboo subject, like suicide becomes a taboo subject, sexuality becomes a bit of a taboo subject. And in my sessions with nurses doing the clinical risk updates, I sometimes got that same sense from people that there is a difficulty and a barrier to asking people about sexuality. And it's kind of, where do you start? What are the right questions to ask? Where do you enter into that conversation with someone? So yeah, I think you're right, Rodri. I think training for people and giving people the skills is vital. Okay. Does anyone else have any thoughts, not just on that question, but any questions on this part of the slide in terms of what might be important to ask, what might be the barriers? Okay, Sandy.
Yeah, sorry. I had intent. People probably don't know me. I'm Sandy Keane. I'm one of the non-execs, and I'd intended to join this conversation to listen, but feel tempted to speak. So please forgive me. Please forgive me if what I say is completely obvious and so obvious, not said. But I just kind of feel that there's the whole thing about person-centered care when they come on, presumably if they come on the ward or where they're known to the service for the first time. It's about getting a sort of holistic history, and people usually like to talk about themselves, and I know in a mental health crisis that will be different, and it may not be at the crisis time, but I guess it's about just talking about life experience and relationship experience. It will emerge the kind of patterns of people's behavior. And I don't know whether there is a training or, please tell me, to what extent people feel confident about, taking that life history. The first speaker, was talking about multidisciplinary engagement, and that's really important, but the one-to-one, of actually having somebody linked to a person so that a relationship is formed, because that's the other thing that I think is a barrier to this, which I know is a later question, but when there are multiple changes of worker and people can't build trust and confidence, then they're unlikely to be wanting to be vulnerable, I guess. And so I suppose it's how we build our awareness of all those factors and make sure that we put in place the kind of key worker, link worker, sort of factors that will build relationship and trust, and then we'll be able to get more to the heart of what people's experience is. Does that make sense?
It does. Thank you, Sandy. And non-exec or not, please feel free. We want you to speak.
Thank you.
James, I think you slightly gazumped Rodri, so do you want to go and then we'll hear from Rodri? James, I think you've got mute on.
I was just going to say, you're talking about like forging those trusted relationships between patients and staff. Now, I've been on wards where there are enough staff for that to happen, and it creates a therapeutic environment. I've also been on the wards where there are not enough staff, and because there's not enough staff, there's not enough time for those one-to-ones and to develop those intimate therapeutic relationships that you're talking about.
And I think that's a really important point, James. And I think that again is something that the trust is really focused on. I mean, I'm not here necessarily to answer everyone's questions, but I do think that there is a lot of focus at the moment around ensuring that we've got the right numbers of staff on the ward to be able to generate that kind of therapeutic environment. Thank you, James. Roderick?
This is a sort of a kind of a sort of follow on for what Sandy said, and maybe sort of connected to what James is saying as well. And I think the other thing is that, I mean, I know we're talking quite a lot about wards, and you know, it's clearly really important, you know, in terms of the ward spaces that they feel safe for individuals to be in. But, you know, we've also got a kind of a duty in terms of when people are in the community as well, I think, to think about these issues. But what I wanted to say, I think, in terms of what Sandy was saying, I think it is really important that we do good histories, and I think that can happen. But what I think one of the things that does happen is that those kind of history taking, when history taking takes place, it isn't always in the kind of most comfortable or necessarily that, you know, they can be often early on in people's experience in the inpatient setting, and it might be that they're not that ready at that point to think or talk about some of these experiences. And I think sometimes this is why I think we've got to, you know, I go back to the training, and I'm probably going to waffle on about this a lot, but that actually stuff can come up in conversations where people have started to build relationships, you know, with the support workers, sometimes with housekeepers, with all sorts of people. Conversations can come up, and I think that, you know, it's that people, you know, it's as a general as a general ability, we need all of us to be able to know how to respond to that, I think, so that these things may come up in good history taking, and they may well do, but also they can come up in kind of quite surprising, in sort of surprising conversations sometimes, particularly where people have, built those nice sort of supportive and trusting relationships.
Yeah.
Vin, it's 11:10. Shall we move on to the next slide, or would you like to stay with this one a bit longer?
We'll go with the next slide. Thanks, Gerka. So in terms of sexuality and sexual safety, I think one of the really key things is the risk management or safety plan. And obviously, I think the missing word there is collaborative. But I just wanted us to think about who might need to be involved in that. What are the key features of a good risk management safety plan? What might the barriers be to developing a robust sexual safety plan with an individual? And how do we promote sexual well-being? Just before we open that up to people, I think one of the things James has said, I think, and I wrote it down because it really piques my interest, is, and James used the words, that the wards are sexualized environments. And I think that's really important to think about in terms of this slide, because if we consider our wards to be sexualized environments, then I think it is vital that we think about this element of safety planning for individuals. But I'll open that up to other people who want to make comments.
Could I actually ask James, could you give me a little bit more information with regards to what you mean by sexualized environments?
I mean that quite often you will have quite a few young people of both genders who don't particularly want to be in the hospital, may or may not consider themselves to be unwell, want to have fun and want to do something to alleviate the boredom. that creates a sexualized environment, listening to sexualized music. That's how I can explain it.
Thank you, that's helpful.
So does anyone have any thoughts, comments, in particular around the slide and what James is saying?
Oh, do I need to put my hand up?
No, Kate, you've done it, I guess.
Okay. Yeah, some unformed thoughts, but I think what James is saying is really important, and thinking in inpatient environments where I've worked before, where there has to be something that makes it safe, but also, as what you said in your first slides, Vin, doesn't create a sense of judgment on individuals, particularly, you know, there's something, there's aspects of this, aren't there, that's very natural and important part of healthy living, and there's how to then not become, so we have to create safety and feelings of safety for people who are there, but also recognise that there's something about allowing people their own personal space in bedrooms, and recognising that we have needs, that we all have needs, but that what is and isn't okay in that environment to keep ourselves and other people safe. I don't really know what my formed thoughts are. They're probably nothing more than just saying this. There also has to be such a openness to discuss people's own sexual needs, which can be, I think, if people aren't confident, then they can be really uncomfortable to have, or to allow. We need to keep staff feeling comfortable too, but just the whole topic needs to be so much more transparent and open. So yeah, a few more thoughts.
No, thanks, Kate. Lee, did you want to say something?
No, that was an accident on my part.
Oh, okay. Yeah, I mean, just from what James was saying, it strikes me that if you just think about the Mental Health Act alone, then we can compel people to be staying on our wards for inordinate lengths of time. And I think that, as Kate is also saying, sexuality is a part of everybody's life, isn't it? So I think there's something really important about understanding that. Lee, your hand has gone up again. Are you doing that to mess with my mind?
No, Vin, I'm definitely not. I think it wasn't an accident the first time I raised my hand, but I bottled it. But I think that probably says something about. So I've joined quite a few of these sessions, and I've always, those people that know me know I'm quite happy to express my views and comment on things. But for some reason, this whole topic is inhibiting me from commenting, and I think that might be a reflection of how perhaps other people feel. I don't know why, and I suppose that's where the confidence and the training is probably needed.
You're right, and I think some of that is about that ability to help people express their sexuality verbally, and to be able to talk about it and get us all past that kind of taboo element to sexuality. I think it is a difficult subject, and I've done countless numbers of sessions for nurses doing clinical risk updates where we are all adults in the room, but it causes people embarrassment, difficulty in wanting to talk about the subject. But I think the more we push that point and the more we get people to talk about it, just like in other areas around mental well-being, the better it will be for everyone that we have an open and honest discussion about it.
And I don't know where that fear from comment. I don't know whether it's just I'm fearful of saying perhaps the wrong thing. Part of this. Yeah, just my reflection, not really a comment.
I do also wonder, coming in there, it does feel like it's really actually interesting listening to people's reflections, you know, that it is a natural thing. For me, it's a very private thing. And for me also, what it brings in is the sense of boundaries, you know, with regards to, we possibly all have quite different boundaries around safety, and where I would think also the kind of sexual safety sits within that. And it's that, how do we manage it that people feel comfortable and safe to explore this kind of topic? Yeah, I agree. One of the things that strikes me from the work that I do, which is sometimes focused around incidents and incident reporting, which then leads a kind of breadcrumb trail into risk assessments, etc., so that I start to look at that wider picture of what risk assessments look like. But one of the things that strikes me is that very rarely do I come across, say, an example for a dram where it identifies straight away that sexuality has been discussed with an individual, or there's any pointers about an individual's sexuality within that dram. And for me, I think sexuality is not necessarily just about sexual vulnerability, is it? Or it's not necessarily a negative thing. I think it's about having those open and honest conversations about sexuality per se, something that I think that the training needs to get to. Okay. Yes, please. Okay, so I don't necessarily. Oh, Kim, you've put your hand up. Was that in association with the last slide, or are you happy to talk now? Or
Vin, I'm ever so sorry. I'm really late joining today, so I've come in on the end of this conversation. I've been listening. The sexuality aspect of the training has been picked up by the Rainbow training, and they've already incorporated that into the last session that they did, and it was really well received. They've added in a couple of extra slides which I can share with people if anybody wants to see them, if there isn't anybody on this call who knows that. But they're introducing the whole of that Rainbow training is about being able to feel safe to ask questions, and you know, we know from lots of other areas, don't we, that it's not that people need special skills to be able to ask these questions. They just need the confidence to know that it's okay to use their existing skills to ask these kind of questions. So that's an angle that they're coming at it from. But they're starting to address this and are very receptive to any future changes that we want to recommend. So rather than introducing another training, there's an existing training there that we can tap into.
Oh, fantastic. Sorry, I don't know why, but my telephone is ringing. I do apologise. I didn't think that telephones rang when you were on these things. That's great. Thank you, Kim. I wanted to touch on this area. I don't like necessarily the wording of alleged perpetrator, because I think people who are vulnerable are vulnerable, and I think that might need some unpicking. But in terms of what I will call the alleged perpetrator for the purposes of this, is some of the questions I thought we might want to think about is how do we manage those risks? And then importantly, how do we make sure that the appropriate boundaries are maintained? So in line with what James was saying about sexualized environments, how do we make sure that we communicate clearly to the patients what we expect and what's not acceptable? Any thoughts?
Can I? That's
You're physically putting your hand up, aren't you, Kate? Which is nice.
I'm doing it in the wrong order. I think I'm tired. I'm getting it all.
I like it. It's nice. It makes it change.
Thank you. So I suppose I've got loads of clinical examples and times when we've gotten it wrong, and the difference it can make when when as a team people do understand, so in managing the risk of that somebody could pose to somebody else in their vulnerability, in their own vulnerability, but in the boundaries with somebody else's vulnerability, when a group of people around that person understand what it's about, there is so much more compassion, there are so much clearer, compassionate boundaries able to support somebody's learning, development. And when that isn't in place, people feel threatened, their own personal safety becomes, the risks feel a lot out of proportion to, and I'm not criticising then ourselves as staff teams too, but there's just something that it can very quickly, something seemingly quite small or has the potential for a really good discussion and understanding and supporting that person with their boundaries, gets blown out of all proportion because we can avoid it, we can misunderstand what something means, and we don't have the confidence like we've described. And I've been in just countless examples of the both, of teams where people can have conversations because they have had some training around how to say, oh, it's really important, as a throwaway example, really important that when we're talking, we make eye contact, because if you look at other parts of my body, I can find that uncomfortable and I can't think, versus I'm not going to go see that person because they always stare at my chest, for example. So that's just a very kind of low grade throwaway example, but the difference in how we work with somebody where those vulnerabilities or things that can activate our own threat system or make them vulnerable to being seen in a really negative way as well. So I think there's a lot that needs to be done in understanding our own reactions to feeling vulnerable and to feeling threatened and what that's about, and then understanding why people do the things that they do, either when they're well or when they're not, because when we understand how that can happen for that person, we can hold and find our compassion.
Yeah, I agree. Okay, thank you. James?
In my experience, you can't underestimate the value of well-trained, compassionate, well-balanced staff members, because when you're in that mental health environment, maybe you don't have sexual boundaries and your people that also support those that lack of boundaries. When you get to the hospital and you meet the staff members there, they might be the first people that you've met that actually have got proper sexual boundaries, and that you can learn from that. It does work.
That's really important. Thank you, James. I was thinking that it made me reflect back to recently, due to COVID-19, I ended up going and doing some work in a clinical area, and I'm thinking about the words alleged perpetrator here, but there was the chap in handover who was continually handed over as someone that needed to be kept a close eye on because of the sexuality element to his behaviour. And I think that lasted over a number of weeks, where at every handover it was staff where there was someone keeping an eye on that person in the environment. And actually a young medic came into handover and said, I've been listening to this now for a couple of weeks, and we're not being clear about what the sexual issues are with this person, and then took the steps to do a deeper review of what was going on. And actually, when he did that review, he discovered that it was something from another team that had been passed on, that he'd made an unusual comment, and then that had grown into something about his sexual behaviour, and that had led to other consequences. So I think there is something really important about us being very careful and considered about the work that we're doing. James, your hand is up again. Did you want to? Sorry, you're on mute, James.
Sorry, that was a legacy hand, sorry.
All right, okay. I love the word legacy hand. It's really caught on with me. Okay, any other thoughts or comments on this area before we move on? Okay, Gurkha. Oh. Okay, so I wanted us to just think about environments. I obviously I'm a nurse, and I come from inpatient areas as well as working in the community, but I do think there is a conversation to be had about the environments that we've got at the moment, and I know that there is a lot of work being done to change those, but I wanted us to think about how do you manage the physical design of the units that we've got at the moment. Do we consider potential for sexual harassment to happen virtually through mobile phones or computer terminals within our environments? And something I really wanted us to think about, and something I've been reading around, is there a way, or how can we provide patients with ways of summoning help? I don't know if anyone's got any thoughts. Kim?
This isn't a suggestion, it's a comment of new fact, is that the new nurse call alarms that we've installed, they are just a slow version of the actual alarm for any other incident. So if you're feeling very vulnerable or very kind of anxious, the last thing a lot of people want to do is set that alarm going, because it just, it gets the forces running, it gets everybody running along until they realise that it's a slower alarm, so a lesser response is required. But we've not got that right at all.
Yeah.
Something we at Forest Lodge, because we don't have modern facilities, we have to, if we have anybody that's COVID symptomatic or positive, our patients have to go down to the bungalow, and in the bungalow there isn't a nurse call system at all. So what we bought was, it's called Sing Call, and the person can have a little device that just, they can either wear it as a watch, and if they want to talk to somebody, they just press it and it vibrates on the wrist of the person that's been either in charge or allocated to look after them. Completely discreet, completely, there's no loud jangling alarms or anything. It just indicates to a person that I need something, I want to talk to something. So that might be something we could think about, something that's a little bit more, you carry it around with you and it's personal to you and it's absolutely discreet. So when it alarms, it flashes up the name of the person or the room number or whatever on the watch. I thought that worked really, really well for us down on the bungalow, and it might be something that we could invest in for situations like this if somebody's feeling vulnerable.
Yeah, I think that's a brilliant idea. I remember, I don't know if you attended it, Kim, but last year we did was it last year? I don't know what years we're on anymore, but it might have been last year. But we did a quarterly learning event around sexual safety, and we had some people from down south. I won't say that.
Yeah.
Were you there, Kim? Yeah, and it was a really interesting session. But I think they were saying that they provided all their individual service users with something that they could have on the body, so that if they felt threatened or vulnerable, they pressed it and a similar thing happened. And I wonder about the investment in that, and thinking about how important that is for individuals given the environments that we've got, because I think we have to acknowledge that we do have blind spots, don't we, that we're trying to work with and around. The other thing that I'm kind of interested in is this the virtual stuff, and how there's possibly a tension between us allowing the use of mobile phones and giving people access to the internet via computer terminals, and what impact that might have. I'm not putting a value judgment on that, but wondering about, as an organisation or as a trust, have we thought about that enough in terms of maintaining safety and what that means for individuals? Kim, is it? Oh, yeah, your hand's gone down. I don't know if anyone's got any comments or. Okay, we'll move on. But I think it's important to say at this point that as a trust we are very focused on the physical designs of our units, and hopefully we can do the work that's needed to make the physical design right, to help in maintaining people's sexual safety. Okay, next slide, Gurka. And I think this is possibly my last slide, and it obviously it's something that is close to my heart because I have links to the incident management processes, and I think as a trust we are good reporters, and absolutely no doubt that inpatient areas report incidents robustly and are very frequent users of that system. But I guess there's something, as well as someone reporting it, there's also the question of how do we respond to sexual safety incidents? How do we behave to make sure that that patients or even staff who are involved in sexual safety incidents, how do we make sure that they're supported? And also, do staff themselves feel safe from unwanted sexual behaviour? And I do know, because I've kind of looked at the data, that there are just as many reported incidents of sexual behaviour towards staff as there are patients. So has anyone got any thoughts or comments? Okay. Oh, Kim.
It's just a thought, this, Vin, but if we're saying that the number of staff and patient incidents are equal, that says to me that patient ones are underreported. Because I find that really difficult to kind of get my head around.
Yeah.
I'm sure there's so much that's going on that's just we're not getting to know about, or we're not reporting.
Yeah, I think that's really important, Kim. I think my sense of it is what is the last bit of what you said, which is we might not be getting to know about it, because I think from looking at the incidents as they're reported, they do get reported quite regularly, and to be fair, a lot of the ones that are reported, and I'm not downplaying this, but they're not at what we classify as the moderate, major, or catastrophic level. They're at the lower categories, so they're reported with some frequency. So I do wonder whether actually we're not seeing some of the incidents, and that's why we're not reporting them, because there are areas where we're not able to be in the ward environments. Coming back to that.
Yeah.
Any other thoughts or comments? Someone's got the hand up. I'm just looking at who it is. Sandy.
Yeah, it's not a comment really, Vin. It's a question. I think it's I know you said there was going to be something sort of about learning, but in your it's a question really. In your experience of the many incidents that you've looked at and the team have looked at, if you were to, it's putting you on the spot a bit, but if there were kind of 3 or 4 repetitive themes that we need to address as a trust, what would they be, do you think?
Thanks for that, Sandy.
Sorry.
No, it's all right. It is a subject close to my heart, so it is something that I do look at with some frequency. But I think in terms of thinking about, because as I said, we do get with some frequency, we get the incidents where, for example, someone has made a sexualized comment to someone, or someone has tried to pinch someone's bottom, which are really important, and it's important those are reported and responded to as well. But in terms of the ones where we've gone on and we've done further investigation, I think some of the key things that we're seeing are, for example, an individual is transferred into a clinical environment, and the full understanding of what is known of that individual in terms of either their sexual behaviour, sexualised, or their sexual vulnerability is not necessarily translated clearly to the receiving team. So there was an incident recently that was investigated and reported, where the investigation showed that 2 individuals were admitted onto a ward, and both of them had got needs around sexuality, and that was known by the transferring team but wasn't clearly translated for the receiving team. And within, I think, a couple of hours, an incident occurred that the staff did respond to and did report, but it was a sexual safety incident between those 2 people on that inpatient area. So I think communication between teams when people are being transferred is really, really important, so that we understand not only about asking the questions at admission, but we understand historically what might have happened, can ask the right questions and ask pertinent questions. So that's one area. Another is that area about asking about a person's sexuality and considering a person's sexual vulnerability. So again, there was an incident some while ago now where a sexual behaviour incident occurred off site, and actually when we looked at the records and the incident, there was some historical stuff about the young female's background and her sexual vulnerability. And I think not because we deliberately didn't do anything, but I think we were focused on the care and treatment that we were trying to provide for that individual. We didn't necessarily respond to what was known historically about that person's sexual vulnerabilities. And I think they are 2 real key areas that come through quite frequently. So there's something there about communication, receiving and giving information, but also assessment and understanding historical information about sexual vulnerability.
Sorry, can I follow it up with just another question about, somebody earlier talked about boundaries, and that's, you know, really important in terms of having the standards on the ward about what's expected or not expected. And I know other people have mentioned the community, we mustn't forget that, that's really important as well. But what do we have anything that we can give to people in terms of what's expected of things on the ward? I know it's hard when people come in an acute state of mind, but how do we actually tell them what the boundaries are?
Yeah, we do, Sandy. I think it's about 18 months ago now, Andrea Wilson, who's since retired, started a piece of work with the ward manager and their deputies, and it was very much focused on how we can develop an information leaflet for staff and for patients. And from that, we have got a leaflet that's available on wards that can be given on admission to an individual, which really clearly sets out what our expectations are and what they can expect in terms of behaviour, their own behaviour and the behaviour of other people. Again, what's the question about that, Sandy, might be how frequently is that leaflet used, because you can develop a leaflet, but do we understand whether every person is given it? Has everyone got access to those leaflets? So there may be some questions from that.
No, that's helpful, thanks.
Certainly as well, Sandy, the Sexual Safety Collaborative that we're signed up to, there are posters associated with that and work around communicating out to people in our environments. But again, just something else just to touch on there that you said that's really important is it's not just about sexual safety, it's not just about people in inpatient wards. Sexual safety for people who've got mental health and wellbeing issues is important everywhere, whether that's in the community or inpatient areas. Kim? Thanks, Sandy. Kim?
You may have mentioned it, Vin, but there's also the charter.
Yes, is that part of the collaborative, Kim?
I don't know, but it's on the ward. I was just looking at it this morning to kind of just refresh myself with what it said. Yeah, I mean, they're out there physically on the ward, which is a kind of outlines expectations, if you like, for both sides. I do think we have a bit of a poster culture, though, unfortunately, and people stop looking at posters.
Yeah.
You know, you can walk past 10 posters, each one's a priority poster to the person who put it there or the person who created it, but people just don't look at posters in the way that they should. I had to go and refresh myself this morning just to remind myself what was in it. But yeah, they're up and they're out there, so that it is another way of communicating if people want to look at it.
Again, I think that's the same for leaflets, Kim. I think you can give someone a leaflet and that doesn't mean they're necessarily going to read it. Really, the leaflet should be an aide-memoire for the staff to say, I'm just going to talk you through what's in this leaflet. And together, hopefully that would be a prompt for them to have a conversation around sexuality and the environment that the person's going to be in.
It's exactly like giving someone a copy of their care plan. It doesn't mean that they're involved in their care.
No, absolutely, Kim. We've got a few minutes left, and I did say at the beginning, and I'm gonna put Kate and Lee on the spot a little bit, and possibly Kim if you're involved. But I did say at the beginning we are doing some work in one of the Back to Good work streams. I don't know whether Kate or Lee, you want to just tell us a little bit about that work.
I put my video camera on before Lee did, didn't I?
You're it then.
Yeah, well, only, I think we covered the areas that we're sort of focusing on, really. Lee, we're in the early stages of gathering together people who are interested in this this area. And, you know, the good thing is that there's a number of us who are really passionate about improving sexual safety for service users and staff. So it's just trying to gather together what's already been done, so that we're not reinventing any wheels, but looking at where we are now, looking at what's been done and looking at where we need to prioritise improvement, because there's some things that we can do pretty quickly, but this will be an ongoing learning experience. So there are a group of us that meet fortnightly, and Lee has been really, really helpful at kind of helping to gather the threads together, because there's a lot of different pieces of work, and help us understand where we need to go from here. So we've only just done the terms of reference for the group. But if anybody's interested, what we want to do is for everybody to feel like they can input and have a voice and be part of different parts of this work. So whether it's training or whether it's looking at some of the way that the staff are feeling through the staff survey, there are lots of things, there's lots of ways for people to be involved. Lee, is there anything that you would add to bring a bit more clarity?
Yeah, I'd just probably echo some of your thoughts in that this is obviously a really complex conversation to have, but also so much is there's so much work and understanding that's been generated over the months and years preceding today, and I suppose the piece of work we're supporting, it's about acknowledging where we've done enough of that understanding and learning to move to thinking about, okay, well, what are the themes that have emerged from this and what are we doing to try and address those? And similar to things like the leaflets and posters and training, what I've seen is there's some really good ideas which have come up to address some of the challenges which we know exist. Part of it is to take those ideas forward rather than creating new ideas, because sometimes generating ideas is the easy bit. The hard bit is following through on those. So we've got a leaflet. Is that handed out to everybody, or is it sat in a cupboard somewhere? Actually, is handing out the leaflet to somebody enough, or should it prompt a conversation? If those conversations aren't happening, why aren't they happening in the context of the wards? If it's the pressures, then how can we spread the burden away from one professional group so all professional groups can have those conversations? So it's basically really taking that conversation to its nth degree. Sorry, that's my daughter.
Well, I'm hoping, Lee, as well, that's not a tail that you've got there behind you, and that it's just
giggling out.
It looks like you're wagging your own tail there, Lee. But
yeah, some strange things have happened during lockdown.
Yeah.
I've grown a tail.
Could I just make people aware so that it's gone slightly over time? So if we can, to maybe wrap things up.
Can I allow James to come in, Gurka?
Of course.
For a final comment, James.
I was just going to say, I think it would be really important that when you first come onto the ward and when you have your first induction, that you're told about sexual safety at that point. I think that's really important. And then if there could be a follow-up meeting as well, like one-to-one, just to reinforce the message, I think that would be awesome.
Brilliant, thank you. Well, thank you, everyone. I don't know what other people thought, but I got a lot out of that session, and I think other people listening to it, it'll stimulate conversation and more talk about the area of sexual safety. So thank you.
Also, just to say
and I think, are we calling? Oh, sorry,
just to add, Vin, so the chat option will stay open. If people still have any thoughts or comments, do please feel free to add to the chat option. Thank you, Vin.
Thanks, everyone.
Bye.
Thanks, Vin. Bye.
Thank you. Bye.